So I'm going to start with just a basic definition of implicit bias that I'm hoping we're pretty familiar with at this point. It's been kind of the focus of a lot of conversations across our campus in the last couple of years, and especially this year with the events that are happening both locally and nationally. But I want to highlight here something I think is very important, and that is that last sentence, that often our implicit biases contradict our own values and the things that we hold as important. And I wanted to share just a quick story, a personal story about that to kind of center our conversation today. So I was recently with a dear friend at the hospital, over at the VA hospital, as he was receiving a very serious medical diagnosis, a cancer diagnosis that was terminal. We weren't expecting that at that appointment, but at that, that was what happened. And so I'm sitting with this person that I love dearly. We have this really hard information to hear and process. And then they sent us right from the oncology department, and they said, we want you to go see your primary care doctor so that they can review your medications with you. And so, I left with my friend, walked with them to their primary care clinic, and we walked into an office, and a woman sat down and started going over medications. And the whole time I'm thinking internally, when are we going to see the doctor? When are we going to see the doctor? And it took me about 10 minutes into the conversation with the person sitting in front of us for me to realize that we were talking to the doctor, in fact. And I think in that moment, it just reminded me that implicit bias happens to every single person. I have dedicated my work to making sure that women are represented in the workplace. It's a value that I hold very dear, and one that if people were to ask me about my core values, I would absolutely say equality and opportunity, regardless of gender, is a value that I hold dear. But in that moment, my brain was doing something different. And I think that's important for us to understand about implicit bias, is that in that moment, my brain was on survival mode, trying to focus on, maintaining my composure while supporting my friend. And so that critical thinking that needs to happen in order for us to sort through the information that the brain is taking in was not available to me in that moment. And so I just want to share that as a way to help us all understand that implicit bias quite often happens in contradiction to the things that if we were to have an intentional conversation might reflect something different. And so today, as we have this conversation, I wanted to have us focus on understanding the impact of implicit bias from three different levels. One, the personal, so how does it impact us personally? Second, from a structural perspective, so how do we understand the ways that systems are set up to not mitigate the impacts of implicit bias? And then from a practitioner level, so as we think about ourselves as future healthcare providers, what are the ways that implicit bias could potentially impact our ability to be an effective healthcare provider? And then I want to look at some responsive strategies in relation to those three areas, so personal, structural, and practitioner. And so I think these are things that are important for us to think about on the personal level, that these are the real, often physical implications on the impact of implicit bias and microaggressions. And important to keep in mind here that this is not always just a one-time event where something happens, but a lot of times these are things that compile over time. And so small things that sometimes make us pause, but then we write it off and we go on. But those sorts of experiences tend to accumulate over time. And what we see is an impact on our ability to problem solve, our ability to learn, our ability to work well, and just an impact on our overall physical health, because all of these things over time can impact our physical health and well-being. And so these are important. There are a lot of ways to address this, and we're going to talk about that in the second part. But I think it's important for us to recognize that there is a personal impact when we are the target of implicit bias and microaggression. From a structural perspective, we have to understand that there are policies and practices that sometimes can perpetuate the impact of implicit bias. When we think about higher education specifically, I think it would be wise for us to take a critical look at our admissions processes, our hiring practices, our promotion and tenure policies for faculty, curriculum and how it's developed and whose knowledge we're valuing as we develop curriculum. We're starting to have those conversations among our health sciences faculty this month and in October, and it's I'm excited that we're finally starting to have those conversations. Also, the role of the institution in its communities. So VCU and VCU Health has a specific role to play in our community, and the impact of implicit bias from a structural perspective means that we need to understand how the community sees us as an institution and how we can forge a relationship that is productive and meaningful for the community. But the impact of implicit bias on how we go about that is something that we have to take into account. And then very importantly, from a practitioner perspective, if we're not aware and if we're not understanding how implicit bias can impact relationships, then there is going to be, I believe, a direct impact on the quality of the healthcare that we deliver, the impact on our ability to work in an interprofessional context. So healthcare is a team endeavor. And so if we don't understand the impact of implicit bias on us as practitioners, it is going to impact our ability to work together with our colleagues to affect positive patient outcomes. And then again, community relationships. So understanding who you are in relation to the community that you're serving is also a very important place for practitioners to develop some practices that will help us mitigate the impact of implicit bias as we seek to build those relationships in the community. I'm going to stop right there quickly and just ask any comments on these three areas, anything that you think is missing or any observations you want to share. Okay. All right, I'm going to proceed. So I think anytime that you're thinking about addressing issues of implicit bias, the first thing that you need to think about is what you would like the outcome to be. So on a personal level, if you're planning to address an issue or an injustice or something that you feel needs to be addressed, I think the first thing for you to think about is what you want to have happen in that scenario. So is it that you want an apology? Would you like to see some sort of consequence? And if so, what do you think that should be? And who would be the appropriate person to address that with? Is it enough for you if the behavior that you're calling out stops? Do you want to cultivate a better relationship with the person or the system that is engaging in the behavior that's resulting in implicit bias? And so the clearer your goals are, the more likely you are to get your point across in a way that others can hear it and respond to it. I always recommend that the first thing you think about is safety. And so, you know, if we think about those health impacts of implicit bias, the first thing you need to think about is what your own well-being means to you and how that might be impacted if you proceed. And so the very first thing to think about is safety. That is safety related to your personal health and well-being, your mental health, your position. You know, perhaps there's an issue with you and a person in a higher level of authority. And so those power dynamics can also mean, you know, often mean that we have to take some time to think about what the risks are versus the benefits when we choose to speak up. And that can be a hard thing to make decisions on. And so talking to people that you trust about how you might want to proceed is very important. The second point here is to consider thinking about implicit bias on three different levels. And so content, is this a one-time incident that you feel can be addressed just by a conversation? This was said, this is how I received it, this is what I'd like to see as a change in behavior or a change in practice or a change in our relationship. Is it a pattern? So are you noticing a series of incidents, and these are things that you want to bring to someone's attention? And so if that's the case, again, just thinking really hard about what the goal or the outcome is that you have in mind there. And then is it a relationship? Is the impact of this pattern of behavior going to mean that you can't work productively with those people? Perhaps it's a group that you're working with, or a team. What is the value of the relationship, and what are you hoping to accomplish by bringing this forward? And so thinking about how you want to approach it. First, is it safe for you to do so? But then secondly, what is it specifically that you'd like to address? Is it a one-time issue? Is it a pattern of behavior? Is it more about improving a relationship, whether that's a working relationship or a personal relationship? So thinking about this, and maybe taking some time to write down what your goals are so that you can work through the issue productively. When we think about structural bias, I sent Chelsea an article to go along with this presentation that I hope you all received, that is about developing what we call structural competency. And this is something that I would love to see us embrace in our health sciences education, really in our education period at the higher education level, because I think that what we have to make sure of is that we are developing the skills to identify the structures, the policies, the practices that have been made upstream, as this definition shows, that impact downstream issues such as healthcare, food delivery systems, everything that goes into what we call social determinants of health. What are the policies and practices and the structures that are in place that continue to cause issues for people to access healthcare in our communities? And I think this is a question for education. I think it's a question for just about any discipline for us to be thinking about. And so how do we develop some competency around these things so that as we're looking at healthcare and patient outcomes, we're thinking also about the structures that are in place that are going to continue to have a negative impact. And so in that article, the authors gave us 5 different areas of structural competency. And so the first one is about identifying factors beyond what's reported, essentially, is what they're talking about here. And so if you have a patient who is what we're calling non-compliant, or what we're labeling non-compliant with a medication regimen, for example, are we thinking about behavioral issues, but also are we thinking about access to a pharmacy, access to health insurance to obtain those medications? Are we thinking about the other things that might be impacting that patient's ability to follow what's been laid out for them? And so we're not just looking at what the patient's responsibility is, but we're looking at the whole system, and we're identifying structures that may be impacting that person's ability to do what's being asked of them. Developing an extra clinical language of structure. And this is really about thinking of other disciplines that perhaps could inform the work that we're doing. And so we can think about, and I think we've done a good job in the last couple of years around identifying social determinants of health and thinking with our community about how to remove those barriers for our patients. But are we also consulting other disciplines? So are we looking at education or art or biology or chemistry? Are we looking at other disciplines who might be able to inform our conversation about structural barriers? Or are we just focusing on our clinical experience and the things that are directly impacting the patient from that perspective. And so I think it's important for us to think about other disciplines that might be able to inform the work that we're doing. Urban planning and development, architecture, all of these disciplines probably have something to say about how communities are built, how transportation systems are designed, and could help us develop maybe stronger advocacy efforts if we're looking across disciplines. Rearticulating cultural presentations in structural terms. So this is thinking about, for example, transportation, which we've identified as a social determinant of health, is also a structural vulnerability. It's not just a social determinant of health, it's also a structural vulnerability. So how are we thinking about the things that we're seeing in patient presentation when we're labeling these things as preferences, or we're ascribing them to perhaps cultural preferences when maybe they could be related to structural issues instead. And so thinking very carefully about how we're labeling patient behaviors, and maybe thinking critically about what structures might also be in place that are, again, presenting barriers for that patient. The fourth one speaks to imagination, which is something that I think we have to acknowledge that there's a responsibility, I think, in healthcare for us to use imagination and to think beyond the obvious. And so we have to recognize that these structures that have been put in place reflect very specific decisions that were based on financial, legislative, or maybe community input, but most likely financial, legislative, or political decisions and determinations. And so because of that, these structures are not permanent. They should be able to be changed to reflect the needs of the community. And so how can we imagine a structural intervention that would make a difference in the lives of our patients and the community that we're trying to serve? And then finally, understanding that there are limits to medical education's goals and endpoints, and that the point at which we are at our limit in the healthcare field to solve these problems, how do we begin to work with the community to imagine something different? And so structural humility is what the authors call that. And so how can we develop the skill of recognizing the limits within our profession? And then how does that compel us to engage in meaningful conversations with both other professionals outside of healthcare, but also, and most importantly, our community? And so I strongly recommend that you spend some time thinking about and reading that article and reflecting on it in your own work as you engage in your healthcare education, and thinking about how you can start working some of these things into your approach to healthcare, your approach to patient interventions, and developing relationships with them. So from a practitioner perspective, cultural humility is considered a responsive strategy to mitigate the impacts of implicit bias. And this actually comes from the work of social workers back in the late 90s. And I think it has great promise for us in healthcare, which for a long time has focused on cultural competency, which is important. We want to make sure that we're developing competencies, but I think that the idea that we can never be fully competent in someone else's culture and experience is probably misinformed. But these authors recommend taking a position of cultural humility, and they give 3 action-oriented practices, so 3 things that we can all do to mitigate the impact of implicit bias. And that is a lifelong commitment to self-evaluation and self-critique, a desire to fix power imbalances where none ought to exist. And so just setting intention that as you move into professional practice, that you're paying attention to those power imbalances and actively taking steps to address it. And then aspiring to develop partnerships with people and groups who advocate for others. And this is particularly important, I think, as a healthcare provider, that you understand the community and the people that you're serving, and that you're developing partnerships with community organizations and groups who are advocating for the patient population that you're serving. So I think that's a really important approach to take. And the other one is asset-based healthcare. And so this is looking at our patients not as people who have deficits only, but as people who have a rich network of assets, both within themselves and within their community, that help to promote their well-being and serve as this definition says, as a kind of a buffer against life stresses. And I'm sure if we all take a moment, we could think about our personal assets, the things that we would count as assets. Maybe it's resiliency, stubbornness, a willingness to be open to new ideas. Those are all assets, and our patients come to us with those things too. And so how can we, in our practice, make sure that we're looking for the assets as well? And how can we help to connect patients to those assets? How can we connect to those assets on behalf of patients to help them thrive and not just follow a treatment plan? This just gives you an idea, a visual representation of all the different ways that that we could think about the assets within local communities and how they work together as a strong web of support for ourselves, for the people that we serve. And then finally, something that I strongly recommend if you're close to graduation, or if you're getting ready to move into practice, to start thinking about a professional action plan. And these are just some questions that I would suggest that you think about. Maybe answering them now would be really interesting to you, and then coming back to them a couple of years later to see if they're still operational for you, if the answers change, if they're different. But I think it's important for you to have a plan. If you graduate from VCU and you stay in Richmond, and I hope that happens, we love to see our students staying in the area and practicing here locally. But wherever you go, that you're focusing on that particular community, what their history is, who they are as a community, and how you can work with them to achieve community outcomes related to health. And developing a professional action plan is one way to do that. I think it keeps you focused on what the priorities of your community are. I think it keeps you focused on what's going on in your local community. One question I want to highlight here is, who am I seeking out as experts in my community? I think that's a really important question, because if your only answers are other healthcare providers, you might want to go back and revisit who you think might have community knowledge and history that could be valuable to you as a healthcare provider. Again, as a way to offset whatever your biases might be coming into a new community. So you want to make sure that you're paying attention to multiple stories, multiple narratives as you move to a new community, and you start asking them to trust you with their healthcare. I think it's an important thing to consider. Okay. So that was a ton of information. And I think we have about 20 minutes for conversation. So I would love to hear your thoughts. Ruth, can you say more about healthcare interior designers?
It's amazing how we still can't find the mute button. I'm like, where is it? No, I'm one of the few. I'm a VCU Arts MFA student in interior design, but I spent 15 years practicing healthcare interior design. So I've worked at Carilion Health System, the Veterans Affairs, and then I recently was a construction manager for Riverside Health System. Came back to VCU, looked at all these different degrees because my bachelor's is interior design.
Mhm.
And then I went, no, I'm really passionate about interiors and how they affect people. And thankfully, I'm like one of like five, I'm exaggerating, maybe 500 or 600 healthcare interior designers in the country
Uh-huh.
that have truly specialized in that. So I kudos to you for all the things. Teaching sophomore designers, and the manifesto is something we're working on. So I
Mhm.
took some pictures of your personal,
Yeah.
the professional plan, but just healthcare designers are there. VCU has them. Every health system has them. As you guys move into your profession, find the facilities management department and find the person that helps you, knock down these barriers. And I think I'm always careful how I say this. Some of my cynicism with why I had to come back to school was that I was frustrated that there were very clear ways to do things that were better, and we weren't doing them because it was too hard or the population didn't need that. And that was one of my like sitting in meetings that really did get me cynical, like,
Mhm.
and designing at people versus designing for people is something that I'm really passionate about. And I have been very guilty of designing at people as an early designer, because candidly, you can't, sometimes you don't have the street cred, excuse my language, to kind of go in as a 25-year-old in a health system to go up to the president and be like, hey, do you know what's happening in the ICU? Like, it's not working.
Right.
But yeah, anyway, I'm glad to be here. Healthcare interior designers is my soapbox because they're out there, and there's probably a handful of them that work in your health system. And like you said, it's like, who do I find that can help me with this issue? And then health equity. My thesis is in health and design equity in space. Yeah, so I hope that's
Yeah.
appropriate.
No, I love it. I think, and it just brings home the point that we get so focused, I think, in healthcare on treatment plans and how what we're doing as a provider is going to impact the outcomes for the patient. But there is so much that goes into that. The design of spaces is is a huge contributor. I mean, I even think about myself and how I feel when I go to a new doctor's office. Like, I'm really taking in everything that's around me, and do I feel welcome here? Do I feel like this is a place that's going to care for me? Do they reflect the things that are important to me? You know, so and coming from a disability services background, I'm always interested in how spaces are designed at instead of for people with different abilities. And so yeah, thank you for that.
Wonderful. And just, in my last position, I was going between Medicaid nursing homes and some of our most rural communities in Virginia. And then the same day, I would go to our retirement communities, high end, private pay, owned by the same system. And it was like this brain shift that was so hard. And interior design is a whole other conversation and how it applies to healthcare, in terms of what people know about interior design and what we actually do. But it is, their disparities in the built environment are obvious, they are fixable, they are in our face. I watched somebody like my grandmother who worked forever and ended up going on Medicaid, at the end, right? When she had to swipe that last $500 on her check card and so she could pay the cable bill in her nursing home. And I think that was one of my first moments where I was like, what? Like, we're doing to people? Like, how does that work? So kudos to you guys. I've always said I could never be a clinician, ever. So yeah, that's my passion, is making those spaces be the messenger that they should be, and then getting our spaces back, getting those boardrooms to stop saying things like, for that population, we should do this. And I think that's a code for other things. And I don't blame those. Yeah, I don't blame those leaders. Like, this is an insane industry, right? I've worked with some really, really great people over the years, but yeah, it's like, when can we step back and be like, have we talked to, quote, that population, and then, yeah, just the individual versus the population, right? So thank you for this. I appreciate it.
Yeah, I'm interested in to hear um, thoughts on the structural competency. So building structural competency, and I don't know, does that seem overwhelming? does it seem realistic or even necessary when you think about um, maybe your current role, if you're currently working in a healthcare environment, or any other environment, really.
Well, I don't mind speaking, Lisa. I'm Sonia Lamb Barnes. So I'm not actually a healthcare professional, but have worked with undergrads who want to go into the healthcare professional, and now working with graduate students who are in the profession, and working, with students in terms of their interviewing skills and how they're presenting themselves. And I really, the issue that you brought up about cultural humility versus cultural competency, I think in some ways cultural competency has become like that buzzword that folks need to know that, yes, I need to be able to articulate that I am culturally competent, but the idea of that humility and having that lifelong commitment to actually look at your practices and evaluating, I think is very important, because that does make a difference, I think, in how you present and how you engage with your patients, how you engage with the community. Even myself, as I think about engaging with students, to really coming from the other side, to really try to make sure that I'm being, cognizant. So really liking that part. And then also when you were to answer about the structural, I think myself right now working on evaluating like the policies that are in place at the university from a student perspective, from financial aid, from academics. What are the barriers to graduation? What are the barriers to retention? And I think if you really, as a structure, look at some of those things, that there are barriers, and it may not only be cultural, but also from the socioeconomic standpoint. So I think no matter what, it's very important that we are continuously looking at policies and procedures that are in place and have they been around since before I was born. We won't talk about how old I am. And how do we, be very intentional about making these changes, and rather those changes coming about being very proactive rather than reactive, kind of where we are now, because of so many things that have happened.
Mm-hmm. Yeah, and I like to the cultural humility framework for me really works. And just like you said, because for me it tends to mitigate some of the power imbalance that happens in a healthcare interaction. Specifically, if you think about, you know, my doctor has said to me before, I don't know what this is like for you, and I'd like to understand more about it, so that we can make good decisions. I had a physician say that to me once, and it meant the world. It really did, because I felt like I was put in a position of having a voice in healthcare decisions, and how we were going to go about making those decisions. And I think it's a very small thing that sends such a powerful message about all of our ability to step out of the expert role and let the patient drive the interaction. And I think that when I interview potential students for School of Medicine, for example, that's one of the things that I'm listening for. Is this a person who can demonstrate to me that they are humble enough to acknowledge that when they're a doctor, they're not going to have all the answers, but that they're going to rely on both a team of people to help them make decisions and the patient as the primary driver of their healthcare. And so yeah, I think those are important things. And the structural, investigating and interrogating the policies that are in place, I think is just critical. I mean, it's just got to happen at every level.
I did read an article today, which I graduated in 2004, so I've watched like the standardization of healthcare, and I've been a guilty party. Like, we do rooms this size and they should work for everybody and blah, blah, blah. And I saw a really great, I think it was Forbes today, that talked about the customization of healthcare is coming back. which was really beautiful to see because it's just a systemic change in terms of like, no, not everybody needs the same things. And I thought that was really great. And just protecting clinicians so they can get paid to do the work they're there to do is something that my first health system was really good at. Carillion Health System. I mean, they're just good. And I think that's an interesting conversation, because how do you bring people to the table and help them understand the whole system, but then also protect them so they can like be a nurse and take care of their kids that night. So that's where I'm struggling in my research. It's like the experts, like who are the experts?
Yeah.
Who are the system thinkers? And that's just an intriguing place I'm going. So the bottom line is nobody talks to the clinicians enough ever. So, and I've been there. So it's like,
I mean, I think that happens at every level. You know, the people who are on the ground doing the work will tell you all the time that the people who are making decisions about the work we're doing do not have enough information about what we're actually doing, you know. And I think it's incumbent upon leaders to spend more time listening to the people that are trying to get the work done. Because that's where you're going to find the innovative solutions every single time. But I also think you said something important too, Reed, and that is making sure that people understand the system and what the constraints are and what the opportunities are. Because too often I find that when we try to intervene or make a change or affect change without all of the information, we get frustrated because it can seem so complex. But you know, I think it takes a lot of time to understand how the whole system is put together before you can start dismantling it and taking it apart.
Yeah, Dr. Webb, that's a great point. That's what I'm seeing a lot with the efforts around boosting up diversity and inclusion and equity efforts in all different industries. And I'm not seeing enough talk about what the structure is and how systemic racism continues to thrive in spite of hiring a chief diversity officer. And I would love to see the conversation start to gear more towards, let's take a step back and unpack this and actually break it down before we just start plopping people in positions, waving magic wands, and everyone's diverse and all about equity and inclusion overnight. Like, that's just not realistic.
Yeah. And two, it's really important, I think, for us to understand why those structures were put in place in the first place, and to be brutally honest about that. And so, you know, I'll take admissions policies, you know, so why is there a legacy, or was, I think it's gone now, but why was there a box that you could check on the School of Medicine application for a legacy application? We could say it was because we wanted to give, you know, the children of alumni extra advantage. I don't think that even scratches the surface of why, you know, any institution would have a legacy option on their applications. And so I think we have to both examine structures and policies, be very honest about what they serve to uphold, what ideas they were meant to uphold, and then we can reconstruct in a more honest way. But I think that deconstruction has to happen too. You know, I'll use this example not to be overly critical, but I think it's a good one. You know, for us at VCU. So some 20 years ago, we had TRIO programs that came to VCU that were, TRIO programs are federally funded through the Department of Education to provide support for underrepresented students coming into college. And they have a variety of programs. They have some that focus on health sciences, some that focus on just undergraduate students in general, regardless of major. They have some that focus on students with disabilities. They have TRIO programs around employment. So we had these programs for several years at VCU, and those programs were successful. You know, got bigger and bigger and bigger and became institutionalized, which is what you want when you have federal funding. You want to see that as a launch pad for institutionalization of practices that produce good outcomes, right? That's the goal, not to be reliant on federal funding forever. And so VCU built University College. All these wonderful resources are available. They get scaled up, they get scaled up, they get scaled up. So why is it that 20 years later, we're at a place where we identify a need for TRIO programs again? So what happened in that 20-year span that that we didn't institutionalize in terms of support for the specific population that those grants were meant to support? So how do we find ourselves back at almost square one, right? And I think that's an example of not bad intention. I think it's an example of not paying enough attention to why the original structures did not meet the need of certain student populations, and how once they got expanded to everyone, we still ended up with a need. And so so I think it's really important for us to dissect and take apart those structural things critically. I think it's got to happen.
Lisa, I think there's also a question in the chat from Martina Hernandez. Why are there such steep fees on medical, professional, and graduate school applications?
Yes, indeed. Yes, indeed.
I noticed that it poses great barriers as for people who often apply to these professional programs that it requires applying to multiple places, and those fees add up and pose great barriers, not socially, economically, but looking at a systemic racism aspect as well.
Yes, yes, I agree. And it's, you know, as you said, it's graduate school applications in general. And I think that if any institution were honest, the cost of doing admissions does not equal what's being charged for application fees. I don't see a justification for that. But it serves as a barrier. And I've heard people push back on that idea and say, but you know, AAMC, ADEA, all these organizations have assistance available for students who can't afford the application process. Why should anyone need to request assistance? Why is there such a steep fee? What is actually being covered in that cost?
But not only that, the criteria that is used to determine who is eligible for those waivers is based upon income and poverty lines. And so while that's true, but there are those that are in that murky middle that we are very much understanding of, that it's still prohibitive to be able to apply, because you know they're putting themselves through school, but they still have to provide their parents' income. So it's, while it's there, it's really not helpful to pretty much everybody who needs it. So that definitely is a policy, but that's, you know, across the board, that those things are not looked at appropriately.
Yeah, and anyone who was following the at least the medical school application process during COVID and understood the impact for students with disabilities who were trying to schedule their MCATs, absolutely outrageous that the disparate impact on students with disabilities in the application cycle, I think is going to have implications for us for years to come. Those of us who have been in the policy advocacy realm for years around this issue have been stating the same concerns over and over and over and over again at the national level. And COVID, like many things, just brought this directly into the sunlight and exposed just a history of bad practices around that issue. Karen, thanks for that question. I am not aware of a campus-wide effort right now, but I do know that there are plans For example, the College of Health Professions has a new certificate program that's coming, a post-bac certificate, I think, coming online next year around health equity, and that I assume will have some information and will address in some way implicit bias. We're asking for and trying to advocate for at least one mandatory course on racism and the impact on health outcomes. Some of you may have seen over the weekend some stories that were, there was a story in the Times-Dispatch, and I think some of the news outlets picked it up, about VCU's efforts to start a required Gen Ed course on racism and its impact on the lives of people in our community. To add that as a core requirement in VCU's Gen Ed. I don't know if you saw that article or not, but unfortunately, they did not credit the actual faculty members who are working really hard on that. And that's Dr. Mignon Guy is heading up that group. I think that's a core group of faculty who are working in that realm. So those are the ones that I know of at this point. I would like to see more, and I think that it's certainly on the radar of our deans. Okay, I think, is 12:50 our endpoint, Chelsea and Logan?
Yes, so we're running out of time. Just want to see if there's any last comments for folks. And I really wanted to thank Lisa for your authentic sharing and your great presentation. I think we had a wonderful discussion. I believe there's one more thing in chat. It says that it would be very helpful to have that type of training for faculty. Well, Lisa's working on that.
Yes, starting next week, yay. So we have 2 faculty cohorts that are that start next week to work on, actually the program is called Reimagining Health Sciences Education. And so part of it is to address the ways that implicit bias are manifesting in the classroom and in the curriculum, and how we start to decolonize our health sciences education. So I am thrilled. I'm so excited about that. This is our pilot run this fall, and then we'll be expanding it in the spring. And I'm so excited because the people that are helping us put together that training are just phenomenal women who are really committed to this work. So it's exciting. Thank you.